Welcome, everybody. We're just going to give everybody a few minutes to get logged on here, and then we'll get started. Good afternoon, and welcome to part one of our Accountable Care series, a journey to whole person, patient-centered care. Before we get started here, we just need to let you know that the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. And here at the Kentucky Regional Extension Center, we offer a variety of services to help you meet both your inpatient and outpatient needs. If you have any questions about any of our services, please do not hesitate to reach out to us. And then here at the Kentucky Regional Extension Center, we strive to serve as the trusted advisor to healthcare organizations, clinicians, and leaders across the Bluegrass. We have partnered with organizations in almost every county in the state to help improve the quality of care, reduce the cost of care delivery, and improve the overall well-being of the Commonwealth. We have advisors who are located across the state within your communities that understand the challenges that you may be facing. So let us be your resource as we all work together to build a healthier Kentucky. Today's presenters are myself, Alicia Anderson, and my colleagues, Vance Drakeford and Jessica Elliott. And then in today's presentation, we'll be discussing the accountable care landscape and how CMS has responded to the rising costs in healthcare. And then we're also going to review accountable care pathways. And this is the introductory session of our accountable care series. We look forward to providing you with more information on what's coming next in the series later in the presentation. And I'm going to pass it over to Vance to kick us off with the accountable care landscape. Thank you, Vance.
Thanks, Alicia. Well, welcome everybody to our first part in our series of our ACO series. So welcome everybody. So let's get started with our topic here and kind of talk about accountable care. And as we think about accountable care, what the heck is accountable care? So as you look at our slide, it really lays it out in 5 different components. And it's a person-centered care team that really takes that responsibility for improving the quality of care, care coordination, and health outcomes for a defined group of individuals to reduce that care fragmentation and avoid those unnecessary costs for individuals and that health system. And when we talk about accountable care, you've probably seen a lot of these terms as you have kind of researched it or dived into this topic. And looking at those ACOs, what is that? It's really just a group of people, of doctors, of hospitals, or other healthcare professionals that work together to give that patients really high quality coordinated care, like I said, to improve those health outcomes and really lower to manage those costs in a value-based payment model. ACOs, they can be set up in a geographic region, or they can focus on specific patient population or conditions such as diabetes, chronic kidney disease, those kind of things. And when we say value-based payments, that's really just taking payments and paying for healthcare services that links cost and quality and that patient's care experience, and really kind of it's interchangeable between accountable care. And then, of course, the most familiar that we're most recognizable is that fee for service. So that's just the payment system that originated in Medicare, as it says there on the slide, and that just pays those healthcare professionals for the services that they perform. And then you have shared savings. So looking at shared savings, that's just a value-based payment that's designed to give rewards to organizations that keep their costs low, below that total cost of care benchmark, and then they meet certain quality standards to get a percentage of that savings. And then you have what's called a downside or dual-sided risk. So that's baked within that contractual agreement for that value-based program, in which those organizations accept specific financial risk and really a potential loss if your costs exceed that total cost of that care benchmark. So I'm going to let Jessica kind of talk about some cases for spending for ACOs.
Thank you so much, Vance. So as Vance mentioned earlier, talking about what is that definition of accountable care. Accountable care does contribute to a lot of different things. So first and foremost, accountable care is looking at ways to reduce cost of that payer, as well as reduce the cost of care that beneficiary has to pay forward. And there are a lot of different factors that contribute to spending in healthcare, right? And so it's whenever we aren't able to have solid care coordination, whenever we have fragmented care, when there's duplicative testing, that we're not leveraging our technology as readily as we should be. These are all different contributors that create more cost generation and therefore more spending. And so you can see on this slide right here, when we're looking at that global perspective, the US has considerably higher healthcare spending than any of our top 10 counterparts from the OECD. And so this was most recent data from 22-23 performance years. And you can see that higher health system performance, meaning that they have better care coordination, that they have better interoperability, that they have better care outcomes. Those systems like Australia, UK, New Zealand, France, Germany, Switzerland, Canada, they all have less spending, but higher performance, higher outcomes, improved outcomes, as opposed to what we see here in the US. So we are continuing to see healthcare costs rising. We are now at $4.9 trillion in spending for 2023, and that has gone up significantly even from whenever we pulled these numbers a couple years ago. And we're looking at about 14.5 per capita spending in 23. So per individual, this isn't just looking at the Medicare population. This is looking US wide. So again, we're seeing that the costs, despite these conversations, the costs of healthcare continue to climb, and our spending right now does not necessarily justify the outcomes. Another aspect, again, that's whenever you're looking at accountable care, are your patients able to access services, right? And so again, we're seeing on that global trend, the US lags considerably behind its counterparts. And when we're looking at access to care, and particularly in this data set that we're seeing right here, It's going to look at affordability of the care that's being provided, and then also the availability of services at that population level. And so when you think about care availability, right, US patients are going to be more likely than their peers in other countries to report that they don't have a regular doctor or a place of care, and that they have kind of limited options for getting treatment after regular office hours. We also know that there are significant shortages in primary care that also add to this problem of availability. And so when you link back to our definition of what is accountable care, a team-based approach, well, if we have a shortage of physicians, that makes it even more difficult. Same thing with care coordination, right? If patients aren't able to access and build a relationship with a particular clinician, it creates that care fragmentation, and it really hinders providers to be able to have that coordinated care and to really then be able to partner with that patient to improve their overall health outcomes. And now I wanted to just look a little bit of what is actually contributing to the cost, right? And so we know that we have spent if you round that up, 4.9 trillion in 2023 that I mentioned on the previous slide. And we can look and see where it is divided up. And the majority of what we're seeing is through hospital inpatient care, and then also physician clinician services. And then we look at that other personal health care costs. And so when we think about this, our hospital and physician services are really contributing, when we combine those, to the lion's share of the costs overall. And so that is where that focus is now looking at. How do we streamline operations? How do we look at, controlling expenses in these areas? What are we doing to not only have low cost, but also those high patient outcomes to really justify the expenditures? And so this is really the landscape in which we are looking at what has really set the scene and what continues to set the scene for payer reforms, trying to move from this fee-for-service world that healthcare has been in, and we've been dipping our toes in, to an accountable care, a value-based care model. And so this is really, really kind of setting the stage and priming the pump. And so then what I'm going to do now is actually hand the presentation back over to Alicia, who's going to talk with us a little bit about those the response to these out of control costs, the spendings, the lack of outcomes that we're seeing. So Alicia, I'll hand it over to you.
Thank you, Jessica. So to get started on our discussion on how the healthcare system is responding to rising costs, we want to start by focusing on how the health insurers and the healthcare systems have responded. So one of the first areas that's important to highlight is the effort to decrease unnecessary utilization. So that means we're looking at ways to eliminate care that does not add value, or care that might be redundant or avoidable altogether. And then we also want to highlight high utilizer interventions. So these are going to be your targeted approaches that are going to aim at a small group of patients who tend to use a disproportionate amount of care. And that's often because of very complex needs. And when we think about what drives overutilization, we're often thinking about unnecessary emergency department visits, preventable hospital admissions, and then also our readmissions, and then also the duplicative testings. So these issues are expensive and they do not lead to better outcomes. And we do know that a relatively small number of patients can oftentimes account for a large share of our total healthcare spending. And that happens for a lot of reasons, but it often includes things like multiple chronic conditions, unmanaged behavioral health needs, and then social challenges. And then another important strategy is transforming how we pay for care. So instead of that fee-for-service model that we're used to, we're really shifting towards more value-based payment models. And those models are going to reward better outcomes and higher quality care. Bundled payments are a good example. With bundled payments, healthcare providers are paid one fixed amount for that entire episode of care. And that's going to create the incentive to coordinate the care and prevent complications and ultimately make a better experience for the patient. And then our accountable care organizations, or ACOs, are going to take that even further. And these organizations are going to agree to manage the full continuum of care for a group of patients. And like Vance mentioned, that could be geographical, or it could be based on a specific diagnosis. And they're going to be held accountable for both the cost and the quality for those patients. If they deliver their care efficiently and they achieve those good outcomes, they have the opportunity to share in savings. But if they overspend or they perform poorly in their quality metrics, they can face financial penalties. And then our managed care organizations, or MCOs, are going to also play a role in containing the cost. So MCOs are able to negotiate rates with providers. They build care networks, and then they use tools like utilization management to help reduce that waste. And then MCOs are more frequently offering financial incentives, and those financial incentives are frequently tying payments to their performance on quality measures. So when we look across all of these models, we can see a common goal, and that goal is going to be to reduce the cost while improving the quality and coordination of care. So with that, I'm going to turn it back over to Vance, who's going to walk us through how these efforts are creating more value in care delivery.
Yeah, perfect. Thanks, Alicia. Yeah, just piggybacking off of what you were talking about with decreasing that utilization and then reducing the cost, how that all, what that does by doing those elements, you are going to create that value that that we're looking for in care. So it's going to really look at the value in healthcare. It's measured by how those health outcomes show over the cost of achieving that improvement. So you're going to try, that's where you're trying to gain that increased value by lowering those costs and decreasing that utilization, so you get more bang for your buck, so to speak. And that really is going to enable, healthcare organizations to create more value for the patients and for the payers. And it's also going to help, with spending, the need for additional care, and really those complex diseases and chronic conditions from progressing, and the need for additional costly interventions. It's going to add to the cost. So with that, we're going to move along, and Jess is going to talk to us about a little bit of a history of the accountable care.
Thanks, Vance. So I think it's sometimes important to know where we've been so that we can kind of look at where we're at now and help to really forecast, where things might be trending. And so, again, we've talked about, we started out and have been, Medicare in particular, and even, our commercial payers. It has been truly a fee-for-service exchange, right? So the more patients you put through the machine, the more revenue that you earn. And so that initial mindset there's been a lot of, and it's happened over multiple decades, right? This has been a conversation, this has been a problem for many, 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 many years. And so that first started to really get recognized, and some reorganization and changes came into play in like the late 80s, early 90s, where we did start to see the rise of those HMO organizations. We saw, more managed care organizations as well, with whose primary aim was really to just reduce costs, right? And so what ended up happening is that, patients were put into HMO networks. They were paying premiums, but they weren't getting the benefit from it. They weren't able to access services. There weren't enough providers built into their network to really handle the load. And a lot of the ACOs that started out in that time frame, they weren't sustainable. Or excuse me, the HMOs that started out in that time frame really weren't sustainable. And so what we're seeing now, there are still HMOs out there. They are still like the more successful ones are really more tied to a payer specific, an employer specific HMO model that we've seen. But that early iteration just really kind of sputtered a bit. From that, though, evolved the the Medicare physician group practice demonstration. That was one of the very earliest models and really CMS's attempt at shifting risk back toward a provider, but still staying in that framework of traditional fee-for-service billing. Right. And so that was in that early 2000s. CMS did set aside some bonus payments around improving cost efficiencies, but still didn't really have that quality component tied in. And so the results of that were really kind of mixed. And so the next evolution started to take shape in 2010 and beyond. We first really honestly around that time was when the term of accountable care really first came into existence. A little bit of trivia for you all. It was actually Dr. Elliot Fisher in a public meeting with the Medicare Payment Advisory Committee that actually coined that term. And really that argument right there was to really link quality and costs, and that the care itself should be shared among all providers that are a part of a patient's care continuum. And so that's really when we started to first get that nugget of accountable care and aligning quality and costs, and that patient's journey is at that whole patient level and not at that individual provider interaction. We then finally actually started to see in 2008 where the federal government, the Congressional Budget Office, or the CBO, decided to start incentivizing accountable care organizations. And they created an idea of sort of a bonus structure that kind of created that framework for the foundation of some of these ACOs that we have now seen take shape. And then we really started to see an even further look with the Affordable Care Act. And that was the first ACO model that was proposed in that 2010 legislation. And really that started to really become that leader in delivery reform at CMS. And so then in 2012, we really see that first program come into play. So 2010 with the Affordable Care Act paved that way. And then we saw the first years of the Pioneer ACO and then Medicare Shared Savings Program. Now, cut to today, we do have a lot more ACO choices, a lot more APM, so alternative payment model routes that you can go. Medicare Shared Savings is still around and has evolved significantly over the years, as well as other different types of programs. There are ACOs that have arrangements through private payers, and then we have ACOs like our Medicare Shared Savings that those deal directly with Medicare patients. But you can have ACOs form around different types of care settings. You can have, and we'll talk a little bit more about that in some subsequent presentations just around the nuts and bolts of ACOs and ACO formation, but know that your ACOs can leverage both commercial and public alternative payment models. And that's really where it's headed. There's been a lot of dialogue in the last couple of years about the effectiveness of the current ACO structures that we have, especially in the context of Medicare Shared Savings and some of the other some of the other of Medicare's CMMI models. So that's Center for Innovation through Medicare. And so there's a lot, I think, on the forefront of which direction we can go to from here forward. And I think probably in the next couple of years with some additional federal rules coming out, that we'll start to see how that landscape is going to shape and inform maybe even the next decade or so. So with that, I'll hand that over to Vance to talk a little bit more about how our accountable care organizations work.
All right, thanks, Jess. Yeah, lots of history there for sure. And as we think about these ACOs and their objectives, you know, working in your own organization, that your providers and your administration staff, they work with each other and their patients really to manage the health of the patient through, your EHR reporting, your data analytics, and different population health um, pieces of data that you all work with to help with that patient. Well, with the accountable care organization, really their objectives, as we've been saying, they want to increase efficiency, improve outcomes, and reduce those costs of care. That is their objective. So they want to take that data and that information that you're working already with your folks, your patients, and then join with their organization, that ACO, to try to do those things, to try to, improve outcomes and reduce cost and increase efficiencies. And they do that through a contract, through that contractual agreement. It's not an actual insurance plan. It's a contract that you sign to become part of that ACO. And it can be through different types of payers, as you see there. There's the Medicare ACO models, you have Medicaid, value-based purchasing strategies and models. And then you also have different private payer programs that are out there that you are available to look at and decide which program may be best for you, your organization. Now, as you look at, probably the most popular is that Medicare, ACO model, and looking at that Medicare Shared Savings Program, that MSSP. What that is, if you don't know, it's just a group of doctors or hospitals or other healthcare providers who really get together and collaborate and give high quality care to people with Medicare. And they focus on delivering the right care really at the right time to avoid any unnecessary services and errors in their medical service. And when that ACO does well and they succeed in both delivering that high quality care and spending care lessons and spend that more wisely, that ACO is going to be eligible to share in that savings that it achieves for the Medicare program. Sometimes those are known as performance payments as well. But that's the gist of the MSSP. If we look at a shared savings program, it also offers providers and suppliers really that opportunity to create an organization to be held accountable for that quality, cost, and experience of care assigned to that Medicare fee-for-service population. They have different tracks that you can choose, and the ACO selects which arrangement that's going to make most sense for that organization. It's really something that came about from that Centers for CMS's payment system and innovative strategies to get away from volume and move towards that value and outcomes. And so that is that. As we look at the BPCI, which that's bundled payments for care improvement advanced, this really looks at practices, innovation in the care redesign to coordinate care better and to reduce expenditures while improving that quality of care for beneficiaries in the Medicare population. Now, it qualifies as an APM, an advanced alternative payment model, under the quality payment program. So really its main goals are looking at, like I said, the care redesign, provider engagement, patient and caregiver engagement as well, and really data analysis and feedback for that financial accountability. And the last one that I'll kind of dive into that is another one is the CPC Plus, the Comprehensive Primary Care Plus. It was a national primary care medical home model, really that hoped to strengthen primary care through a regionally based multi-payment program reform in care delivery. It included like 2 primary care tracks with that had some incrementally advanced care delivery requirements and payment options to meet the different needs of those primary care practices in the U.S. So that gives you a little bit of a diagram of a backbone, a foundation for ACOs and how they're kind of structured and tracks that are available. I'm going to kind of pass this along to Alicia for our next slide here. That's going to really focus some more impacts of those relationships.
Thank you, Vance. So how exactly do accountable care relationships help improve the quality of care for our patients? So again, one of the keys is really going to be reducing that unnecessary utilization. Again, that includes things like repeated tests or services and things that really don't contribute to better outcomes. And one of the most important things, accountable care focuses very heavily on closing care gaps in delivering preventative care services. So these two things are going to go hand in hand. When we close our care gaps, whether it is a care gap for an overdue screening, maybe missed follow-ups, and then care gaps for unaddressed chronic conditions, we're really giving our patients that chance to stay healthier for longer. And strong preventative care services also allow us to detect and manage issues early. And when we're able to detect them early, they're less likely to escalate into costly and more complex problems. And then another important piece is going to be coordination across the entire care continuum. So from primary care to our specialists, accountable care models are really going to emphasize that communication and shared accountability, which is going to help create smoother transitions for our patients and ultimately lead to those better outcomes as well. So when all of these strategies come together, we get those better outcomes. We use our resources more efficiently. And ultimately, we're going to see more value for every healthcare dollar spent. And with that, I'm going to pass it back to Jessica to tell us a little bit about the cycle of efficiency.
Thanks, Alicia. All righty, there we go. I think our slide's updated. I think the efficiency can sometimes be viewed as a dirty word. It's also can sometimes be viewed as a frustration point, right? And I think that is something that we always have to consider. Previous strategies, previous models have really just focused on cost reductions themselves, whether it's eliminating services or it's reducing some type of availability of a type of a provider or something like that. And really the conversation kind of has to switch a little bit. I've worked with organizations before that said that we already feel like we are trying to draw blood from a stone. And I understand that sentiment, right? Because you're getting less revenue from your payers whenever you're switching from a fee for service to that value-based model. And so that makes it even leaner and even tighter. But I think the first thing, and a lot of folks are already really great at this, but I think there's still opportunity to look at what is value added in your processes, in your operations, and ways that you can help reduce or eliminate some of those wastes. I think just thinking back for me, for my own personal example recently at the hospital, in order to get some imaging done, my son and I, we had to stop and wait at 3 different desks to check in with 3 different individuals to get him registered just to have his imaging done. And so from a patient's perspective, that is highly inefficient. And, just from a time utilization perspective and the staff utilization of that. So is there a way that we can work smarter and not harder? And so looking at that through that lens, right? Because you're getting a reduced revenue from your payers because your patients, in theory, if you're not providing the services, if you're not having the quality outcomes, you're not going to get that same amount of reimbursement. So that's why in that initial step, waste reduction is so critical. But then when you think about the savings that you're able to eliminate, right, or the savings the savings that you're able to capture when you eliminate some of those wastes, that helps you run more lean and again begins to build that case for efficiency, right? Because you can then take and reinvest those savings back in, that it goes back to that provider. Anything that you do internally to your organization, that's going to be returned back to you so that you can then direct it where it needs to go, whether that needs to go into providers, facilities, resources, things like that. You're able to reinvest that and create that structure to provide more preventative, proactive population health management, right? And then once you're able to manage that population, you're tracking outcomes, you are following up, linking patients with resources that they need, that in turn is going to help build that value in care because you're working on outcome improvement, patient management. And in turn, that is going to increase patient volume. So the idea with ACOs and accountable care organizations is that you are ultimately moving the needle to make your population healthier. So they are going to be less complicated. You might be able to have a lower HCC risk scores for the majority of your population. You'll still always have those very sick individuals, but your healthier patients are not going to be clogging up the system as much because you're providing that proactive care. And so again, that value-based care feeds back into that efficiency stream so that you're then again creating and looking for ways to further refine and improve your processes. And it goes back through that cycle, so to speak. So with that, I want to toss it back over to Vance to talk about that overall shift to value-based care from CMS.
Thank you, ma'am. So yeah, let's talk about how you can kind of prepare what to do as you shift from that traditional model into this this accountable care pathway and value-based care. So as you're looking at this, CMS, as we all know, most of you the most popular is that in the quality payment program is that traditional MIPS reporting. That is where a majority of organizations currently are. We have started seeing some transitions for folks into some value-based models, into some ACOs. And that's really CMS's goal and their vision to transition that traditional Medicare and Medicare Advantage beneficiaries into some sort of accountable care relationships by 2030. Well, when somebody says 2030 to me, I think, wow, that's forever in our future. That's way out. However, when you think about it, it's about 5 years away, and almost really 4.5 years away if you think about it in that regard. So it's coming upon really quickly. And as you prepare for these, you're going to need some time with your organization on how to be best prepared for this shift. And so as you think about it, one of those models or pieces of the puzzle, so to speak, is that episodic care compensation. So that's really a lump sum payment or a bundled payment. And it really is a payment model where those providers receive a single, it's a predetermined amount for all your services provided to that patient during a specific episode of care. Now, that episode is a defined period of time, such as something like after a heart attack or some sort of specific surgery. So that is how that episodic care compensation works. There's also some economic incentives that are for streamlined care and lower cost, but it really involves them using rewards, financial rewards or penalties to influence, the behavior of your providers and the patients to achieve those desired outcomes, such as, improved quality of care, reducing your costs, those better health outcomes like we spoke of previously. And these incentives really can be aimed at either individuals or at organizations. And then, of course, the more familiar there at the bottom is that population-based management. I think we're all familiar, most of us are familiar with like chronic care management. It's a population-based management model and different clinic and preventive care focus. And then you have accountability. So that's just where your specialty care management transitions across, multiple providers and systems in those care settings. So as we move forward and looking at, the road to value-based care, we want to start at really the top of the slide here. And we're most familiar, we're starting out with that fee for service. That's where most of us are at for the most part. And that's just that traditional Part B billing for those services you perform. And then we move towards that fee for performance. So that's where we're at with the MIPS program, with those different payment adjustments based upon your different performance rates and scores. That's kind of what we're looking at for that program. And then you're moving towards that third step, which is that population health. And that's really looking at some of you all may be familiar with that MIPS value pathways, those MVPs within the quality payment program that is helping transition to that value-based care. But this model is really linking that quality, high quality and lower cost to patient condition specific populations to help manage care. And then from there, you can move into that shared savings payments. And those are different APMs, your MIPS APMs, that, as it says there, just provides different opportunities for folks to earn a portion of those savings if your quality and cost measures or goals are met. And then the final goal, really what CMS is trying to do is get to those full capitation payments, and that involves providers receiving a fixed, that predetermined sum of money per member per month for all or for a specific scope of care. And regardless of what services are rendered or the number of patients seen, and it's really contrasts that fee for service model where the providers are paid for each service provided. And if you look at a full risk capitation or a type of full capitation that places that financial risk of providing care on the provider, meaning that they are going to have to manage those costs effectively to avoid any penalties or any different types of losses if you're not performing better value and lower cost with better outcomes. So those are the things that you need to really look at. And this is kind of a pathway that it's like of a smooth transition. We have seen some organizations that jump from 1 to 5 even. So, but there is a path where you can kind of gradually prepare yourselves for that. And just know that we are in that transition mode where CMS is looking to have that in full force by 2030. So it's definitely something that everybody needs to start planning and preparing for. And as we move forward here, I'm going to pass it on over to Alicia, and she's going to talk about some things, how to be successful.
Thank you, Vance. So what are some key principles for success in accountable care? First, we have strong quality or clinical quality measure performance, and that's going to be essential. High quality performance is going to drive better outcomes and help us control costs. It's going to help us by making sure we're doing our preventative care measures. And we are also managing chronic conditions well. But along with helping us with our outcomes and costs is going to be critical for your success as a participant in an ACO. And then next we look at leveraging technology. And so ensuring interoperability and maintaining effective financial management. Utilizing our technology is going to help us identify our care gaps more efficiently. And with that, we can better manage both our patient populations and quality performance. And our interoperability is really going to help us support our care coordination across that continuum. It's going to make it easier for us to communicate with other providers, as well as health information exchanges like KHI. And then on the financial side, I think this is a side that we sometimes overlook with our technology, but it really enables us to create insightful reports that can help us identify what's driving up our costs. It gives us the opportunity to look at specific procedures or even to find our high-risk patients. And with that, we can take more timely and informed action to pinpoint those costs and help to start reducing them. And that leads us to the importance of strong care coordination. It's so important to have a well-structured coordination plans within our organizations, but just as importantly, we need those plans across our partner networks. Effective coordination is going to help streamline our services, and it's going to really help reduce that unnecessary or duplicative testing. And it's going to ensure that our patients receive that efficient, high-quality care. And then accountable care also emphasizes patient activation and experience. We often measure this through tools like HCAHPS. We want our patients to be satisfied and we want them to be willing to recommend our care. But just as important, or maybe even more importantly, we want them to be actively engaged in their health. When they are actively engaged in their health, that's going to be really key to helping achieve better health outcomes for those patients. And when all these elements come together, we're going to strengthen our clinical practice and our care delivery. So ultimately, this is how we're going to reduce those costs and improve those outcomes. We really need to work together and make the most of our technology and our resources, and really focusing on developing and maintaining those partnerships. So with that, I'm going to pass it to Jessica to kick us off with the essential elements of accountable care.
Thank you. So the first one I want to talk with you all about is community and clinical linkages, right? So looking at that component, this is a major influencer in our patients' ability to access services, and then also to be able to have the tools that they need to be able to better manage their care and their outcomes. And so whenever you bring in that community clinical linkages piece in accountable care, you're really, again, helping to grow the accessibility of your services and allowing to remove some of those or reduce some of those barriers for those patients to be able to access services. And it also really, it ties into that patient activation or engagement. Whenever you're helping to connect them, if they have diabetes and you're able to connect them with a food bank or a voucher program for them to be able to have resources to nutritious meals that fall within their diet plan. Being able to leverage our tools, right? Having a set screening tool, such as the Prepare tool. There are all sorts of others, but Prepare is probably the most common one. But having those tools to be able to even begin to do the screenings to identify needs, and then finding a way to integrate those tools into the patient record and documenting so that you can be able to know what resources your patients have been linked to, and to be able to help inform future strategies. Alicia, do you have any other thoughts?
I think it's really important that we grow our partnerships. So we really need to know who our community-based organizations or our CBOs are, and then we need to actively engage them really as partners in addressing social determinants of health. And then once we have those relationships, the next step is establishing that bidirectional referral pathway with closed loop communication. This is going to really help us ensure that when we refer a patient to a CBO for support services, there is follow-up and feedback, and that allows us to track our outcomes and coordinate our care more effectively. It's going to help us address unmet social needs while strengthening the overall care delivery. And then it's also important to know that while we're communicating effectively with our CBOs to build those strong partnerships, we really want to gain a clear understanding of what are their resources and their capacities within the community. Vance, do you have anything else you'd like to add?
Well, sure. I think everybody can see our next answer, right, with the community health workers. But if you have that opportunity and you're fortunate enough to have a community health worker embedded into your system and your practice, make sure you use them. They are a wonderful resource to really get with that patient, to get them more engaged in their own care, and really help, coordinate those different referrals, different linkages to different partners for resources. And they're just a huge help. And if you don't have one, if there's any opportunity for you to get that to utilize a community health worker, make sure you do, or try to find out where you can, because they are a wonderful resource and can really make a difference in that care coordination piece. And so as we move on from the community linkages, another big element that's really essential is that financial health. And so looking at this, I think we all know what we need to look at for that a lot of times. And that's, we need to look at that waste reduction like we've been talking about. Don't have duplicative testing, decrease those redundancies, lower those ED visits and rates, and readmission rates, and utilize your staff clinicians to their full licensure so they can help with that reduction. And then I'll pass it on for our next topic for somebody else to go over, for Jess to help you guys with that.
So, we with CMS too, they are good if you have high costs, but in the lens of CMS, if you have high costs, but you also have high outcomes, that's okay. They prefer it when you have great outcomes and low costs, right? But it's when you have the high costs and the poor outcomes, that's whenever you get in the red. And so looking at who are driving, the types of patients, the populations of patients that you care for, that's one of the easiest kind of low-hanging fruit kind of things that you can do, is to look at who your utilizers are. Do you have a lot of patients who are readmitted within 7 days post-discharge, right? Are you working on doing care coordination? Are you able to do TCM or CCM with those patients? Looking at, the disease states, the disease prevalence, and the costs associated with your patients. Those are some of the ways that you can then be able to look at how you're directing resources, right? So if you have a large diabetes population, are you leveraging the technology and resources? Do you have a DSMES, Diabetes Self-Management Education Support Program, that you can refer those patients to help better provide self-management and activation with that patient? So starting out looking at who your patients are, what they're spending, and that type of analysis is critical whenever you're trying to make sure that your financial health is strong.
And I think it's also important that we identify and understand our vulnerabilities. So we know that if we're providing safe and high quality care, we're going to help proactively reduce the risk of medical errors, but it's still so important that we use our near misses as indicators of potential issues. And that if we leave those near misses unaddressed, it's going to lead to real and costly events in our organizations. So it's really important that we implement strong quality improvement programs, not just to increase our quality performance, but also to help us foster a culture where safety concerns are reported and acted upon. And then just as importantly, we need to create an environment where staff are feeling empowered and encouraged to really speak up about patient safety. And then we need to consider where our patients are seeking care. It's really hard for us to control costs that are not incurred within our organization, and those costs are a lot harder to manage. So we may not have direct control over those expenses. If we have effective communication with our networks and really strong care coordination plans and practices, we can kind of help mitigate those costs and improve that overall value. So the next essential element of accountable care is going to be leveraging technology, and that's going to start with EHR optimization. So one of the first steps there is really reviewing our quality reporting structure and beginning with data validation. We need to make sure that our data is clean, accurate, and reflective of the measures we're tracking so we can use it meaningfully for performance improvement. And then it's also important that we take full advantage of the tools that your EHR already offers. So many systems are going to include modules with dashboards and reporting platforms that are going to allow you to monitor your current performance as well as trends over time. But this is going to look a little bit different for everybody depending on your EHR vendor and then also your organization's internal IT capabilities. So it's really important that you understand what's available to you and then who are your internal resources and then how can they help support efforts like maximizing those tools that you already have and then even developing custom tools that are going to really help meet your quality needs. And then also many EHRs can help identify care gaps. So we really want to structure our visit workflows, both physically and electronically, to help support those help support closing those gaps. And then we also want to use the data from those care gaps to build reports that can help us proactively identify those care gaps and get them closed more timely. And that's going to help with both quality and efficiency within your organization. And then Vance, can you help us a little bit understand the importance of the clinical documentation?
Sure. Yeah, so this is really important, utilizing, the best documentation that you can, or, doing that so you can adjust the workflows that are necessary. But another big component of this is that coding in your billing and coding, so you get that appropriate HCC coding embedded into your documentation, so you get the best credit you can from CMS and other payers for your patient condition levels and their risk scores. So make sure this is really important that you're reviewing that and making sure that all of that coding is appropriate to help to get you the best scores available for yourselves. And then looking at interoperability, Jess is going to talk about that.
So I think you have to look at interoperability at kind of two levels, two different concepts. You have your internal systems interoperability, right? Is your EHR separate from your financial component, your registration component? How do your systems talk with each other? Because that can be a barrier to being able to extract data out of your system to be able to look at your finance, your performance, your quality metrics. So look at your internal capabilities. Also, you want to leverage your technology around health information exchanges, knowing where your patients have been, especially when they're seeking care outside of your sphere of influence, outside of your organization. Having those connections, those bidirectional connections, whether it's through great services like KHI or maybe something else that's through your vendor on a national exchange level, but making sure you take advantage of those. Next, I want to quickly just talk with us a little bit about patient experience. I know we have just a few minutes left, but I think one of the most important things we can do is to keep our patients in the loop about this, to actively solicit feedback, but then also to not just to gather the feedback, but how do you share that mechanism back with your providers, your staff, to be able to then action change so that your patients feel like they are being heard and listened to. So taking it that next step other than just surveying.
I think one really good way to do this is including patient and family advisory councils. And so you can build these with groups of patients, family members, and even include healthcare providers. When we have these groups come together, it really allows us to hear the voice of our patients that we're serving and understand their experiences through that lens. The structure is really going to help us understand what we were doing well, but more importantly, where we can improve from that perspective of patient and family members. This can help us drive our quality improvement efforts, but it really enhances that patient engagement. And then councils can be embedded into a department or clinical setting. And when we integrate them into operations meetings, it really gives us the opportunity to help with organizational decision-making and really help enhance that patient-centered culture.
Yeah, and I think the final piece here is that peer support, just developing that peer-to-peer support programs for your staff members around different chronic diseases or populations that you're working on, and really also making sure you're providing feedback to these folks and results, performance results to your peers so they know exactly where you stand. And then as we look at here at our next slide for our essential element here, our slides are moving slow today. Chronic care and population health management. That is another very important piece. You know, you want to expand your access so you can make sure you get those patients in timely manners. And you can do this with your different scheduling template schedules, make sure they're standardized, and maybe offering after hours or additional nights and weekends to get those patients in.
And also think too, we've talked about reducing readmissions and ED utilizations. Discharge planning is critical, right? And then also too, recognizing perhaps if you aren't a part of an inpatient facility, but making sure that you know when your patients have been admitted to a hospital and when they're being discharged so that you can get them back in for a follow-up timely. So looking at how can you use CHWs, how can you use care navigators or other health staff to really leverage working on getting those patients with that follow-up care after they leave that inpatient setting is something that we find is really important in that overall population health management piece.
And I think too here, our care relationships are going to be very important. And one of the most important pieces of that is going to be primary care patient empanelment. Patient empanelment is going to allow us to assign a patient to a specific provider or to a primary care team. And when we do this, it allows providers and teams to take accountability for that patient's care. And that allows us to more actively or proactively manage chronic conditions and close those care gaps. And it also helps us prioritize and reach out to our higher risk patients. And then building those relationships again is extremely important. Those relationships with our referral partners, provider networks, and our health information exchanges. This allows us to have that bi-directional communication that's required for timely information sharing and really that ability to review that external documentation that we need to provide the best care. So these relationships really help us ensure that we stay informed about the care our patients receive outside of our organization.
So Jess, are you muted?
I am just talking away to myself. I apologize for that. But no, I just want to let you all, I'm wrapping us up and we'll just take us home here real quickly. I appreciate your all's patience. We have gone a couple minutes over. But I know we've talked about a lot of different things today and we've really only just touched on the tip of the iceberg whenever it comes to ACOs, the quality payment program, all those different pathways. And so we are here to help you here at the Regional Extension Center to really kind of navigate this world. What types of payment models are available and just some criteria on ACO selection, what's right for you and for your practice and organization. Additionally, I wanted to just let you all know that we have some more resources out there and available to you all. This is a part of a larger ACO webinar series. This first one is open to everybody, the one that you attended today. We do have 3 additional in this series that are for our clients only. The first one will be held on June 10th. And this one is really going to be focusing on looking at the formation of ACOs, how a provider or a clinic can be tied into an ACO, and sort of that early entry into understanding the different types of payment models that you can participate in through an accountable care organization. Then the next one that we're going to be talking about is going to look at the lens of the quality payment program, right? That one in July, we're going to be looking at how you can participate in the quality payment program to hit those 2030 objectives from CMS, right? So looking at MIPS value pathways and then also the APM performance pathway. And then finally, our last of our series is really going to be about how do you navigate advanced alternative payment models. That's really that next step. We're going to talk about shared savings. We're going to talk about that pathway to becoming an advanced alternative payment model, and really diving in a little bit more around what does full capitation mean, and again, making sure that our organizations are informed about the choices and the risks that they are taking on and the intricacies around being a part of an ACO or creating your own ACO to participate in some of these different models. So with that, if you do have questions, please reach out to us. You can reach out to us at kyrec@uky.edu, or you can give us a call at 859-323-3090. And as always, please feel free to visit our website. A copy of this recording will be emailed to those who have registered for this webinar. So this should be coming out in the next week or so. Just be on the lookout. So whichever email address that you registered for to attend, you should be able to get a copy of that recording. Alrighty, and with that, thank you all so much for your time.